You know him as Dr. K, officially Dr. Miroslav Kovacevic. He's a pediatrician and practices in Hinsdale, Illinois. His talk today is titled Clinical Presentation and Outcomes of PANDAS PANS, 2 Decades of Observation. Please welcome Dr. K.
I got involved with PANDAS by accident in 1999, to be specific, in June of 1999. And since that time, I have seen a fair number of patients, and I did some retrospective studying of my group. For whatever reason, I keep pretty good records. So you're going to see now my group between 1999 2018. Now, this is not the complete list of patients because I included only patients that I had a follow-up of at least 3 years. So I have been updating it for this year, but take what you get right now, okay? Now, before I start, I just want to illustrate for the parents the variety of clinical pictures that these kids come up with. And I think this can be bewildering. Here is an interesting one. A little bit over 3 years old kid, you know, perfectly fine. And one day comes to mother, you know, he refuses to eat. When mother asks him, why is he not eating? I'm saving it for tomorrow. And then next day he said, well, you know what? I'm not going to drink or eat ever again. And he does that, and that's why I put the dates. He does that for about a week or so. Finally, he reaches the point where for 8 days, he did not eat or drink anything. I was admitted to ICU, had children's hydrated, and the gastrostomy was placed. Mother, by accident, found my name, came to my office, and we put the kid on the steroids, and within 24 hours, child started eating. Everybody was very happy. Gastrostomy placement was canceled, but a week later or so, kid became again anorexic and finally was treated with IVIG and has done pretty well. Second one is a 16-year-old from Europe who had anorexia for 4 years, actually was in and out of the hospitals for good 2 years. When I examined her, you know, she was typically anorexic, and what is interesting, her strep titers were significantly elevated. Antibiotic challenge test was positive. She received removal of adenoids and tonsils, and lo and behold, it's been 4 years, she has been perfectly fine. There was no IVIG employed. There was no other treatment given. The last I checked with her was this summer, and she was perfectly fine. The third case is a little bit older young lady who, again, had symptoms since age of 6. So she had them for 15, 20 years. And more recently, for several years, severe anorexia in and out of the hospitals. And at the time when I saw her, you know, she had a weight of about 90 pounds or so, just came out of the hospital. Again, GSI titers were positive, treated her with antibiotics. She improved, and I could document it because her weight has gone just after antibiotic from 95 to about 100 and some pounds, and 2 weeks later, she was at 113 pounds, okay? She was scheduled for IVIG, and she called me and said, listen, I'm in college, I'm really busy, I don't have time for IVIG, can I come one other time? I said, fine, hey, you know. Final case is this is one interesting child because I'm trying to underscore several points that I will bring up later. This child was one of the twins, and believe it or not, when I was much younger, my subspecialty was neonatology, and I attended the delivery of this kid, okay? I followed the kid for a number of years, then they changed the insurance, they dropped out of the practice, and I saw him at about age of 19. He stopped by for the college checkup, and I noticed severe anxiety, and when I mentioned it to him, he opened up and said that he has had anxiety for a number of years, that he cannot function, etc. So we worked him up for PANDAS. He had the typical symptoms. His GAS titers were elevated. We gave him antibiotics. He improved. After a few weeks, the symptoms came back, and he was treated with IVIG and actually completely recovered. Went to college and unfortunately found himself a girlfriend. Okay, not that I have anything against it. And that girlfriend didn't have a throat culture done daily, so she did have a strep, gave him that back, okay, and kid relapsed instantaneously. Came back to Chicago because couldn't stay in college. We removed his adenoids and tonsils, watched him for about 6 weeks. He improved not sufficiently. We gave him the second dose of IVIG, and he has been functioning perfectly since then. So here is basically the population, and as I said, that was from up to the collection of about 2018. The total number of patients was 591. And I kind of put them in 4 groups because they're important later on for efficacy and relapses. So group 1 was 3.5 to 5 years of age. Group 2 was 6 to 12. Group 3 was 13 to 15. And group 4 was 16 to 39. I will reflect on that one a little bit later. You know, typical medical history, I generally do the global scale because it helps me out as assess these kids later. I do limited laboratory workup, beta-lactam antibiotic challenge, and possibly steroid burst. Now, symptoms of PANDAS are multiple. There are symptoms that in my experience have been present in every kid I have ever seen. Those are obsessive-compulsive OCT symptom. It's must. You don't have it, question your diagnosis to begin with. General anxiety, it could be continuous, could be intermittent, also has been present in all the kids. Separation anxiety, reported in all the cases I have seen. Now, there are 2 types of separation anxiety, so I want to make sure that we interpret it properly. In a child 8 to 10 years or younger, the separation anxiety is usually related to the presence of mother or the parents. In children older than 10, their separation anxiety is related to their house, particular room in the house, so it's more to the place where they stay. So keep that in mind, please, okay? Behavioral regression can be discrete, can be overt, but also carefully evaluated patient in almost all patients that I have seen had it. You know, some patients had a baby talk, but you have extremes. I had a 17-year-old sitting in father's lap and sucking her thumb. So all these things do happen, but you have to kind of look for it. Sleep disorders are common and present in about 84% of the patients. Now, one of the things that is misinterpreted, the child cannot sleep or has night terrors, etc. But one of the things that is most common, that these kids, you cannot get them to bed. I mean, they're procrastinating, they're asking for this, they're asking for that. So please keep that in mind. Hyperactivity and inattentiveness have been present in 71%, and aggressiveness, especially toward the siblings, I found it in about 62% of the patients. Now, Dr. Latimer has reported the general hypotonia, and I found it in majority of patients, but this is not your typical lack of tone muscles that we expect with it. It's just that the kids are slumped over like they're 100 years old, okay? So keep that in mind. Now, deterioration in fine motor skills, that includes also handwriting. I will show you a couple of samples later on, but the handwriting is deterioration in handwriting is present in about 89% of cases. Just to make it more interesting, I have a series of about 6 or 7 kids that before onset of PANDAS were left-handed or right-handed, depending on the kid. When they've developed PANDAS, they switched the dominant hand, okay? And then after we treated them, they went back to the previous dominant hand. So it's not a bad idea to ask the parents, you know, is your child left-handed, right-handed, or what's going on? Urinary frequency, enuresis, and daytime accidents are present is also a very high number of patients, 88% of them. Now, the basic symptom of PANDAS is anxiety, and you know, I was so scared I peed my pants. Well, this is basically what you have, okay? Under normal circumstances, like right now myself, you know, I'm not peeing my pants because I have actually 2 sphincters keeping me safe. Interior, exterior. No, listen, I'm not trying to be personal, just physiological. Okay. Well, what happens is when I'm sleeping, my conscious, you know, outer sphincter, it's not working, but I fortunately have the other one that is working. Well, what happens in kids is that the interior sphincter, the subconscious one, fails. So when they are asleep, they don't have that control. They also, if they get very busy, get very excited or very upset, their outer sphincter fails. So that's why you're going to have it. These kids have a almost uniform inability to concentrate. You get reports from school where the kid was straight A and suddenly goes down, teachers are complaining. So, you know, that's something that has to be noticed. Tics and adventitious movements have been noted in 79% of the cases. Now, persistent non-specific abdominal complaints have been also reported in 79% of the cases. And each situation, is it the chicken or the egg, okay? Do they have abdominal complaints because of anxiety? You know, when you get upset, you get stomach pains. Or is it vice versa? They have a abdominal pain causing the anxiety. This is something that I'm actually working right now, but I don't want to bore you with it. Short-term memory impairment is present in about 62% of the cases. Deterioration in learning abilities, especially math, is about in 62% cases. Emotional ability, depression, in 61% of the cases. Increased sensory responses are about 39% of the cases. What is interesting, that in approximately 35 to 40% of the cases, if you take a past history of these patients, you're gonna find an early diagnosis of sensory processing disorder. So this is something to keep in mind. Eating disorder in my cohort was 17%. Now, I wanna be specific. There is a difference. We did compare NIH group, my group, and Beth Latimer's group. And all of these percentages were pretty much the same. The only difference we had was right there, eating disorder. And the difference was that their estimation was higher. However, my standards for inclusion were tougher. I felt that I have to have a documented 10% or more weight loss before I would qualify patient for eating disorder. So that's where the difference is. Selective mutism, it's relatively rare. However, if you include with that occasional stuttering that can be part of the PANDAS, it probably goes from 7 to about 15%. Finally, I've had maybe 3% of patients with intermittent dystonia, and most of them I have documented to be not PANDAS related, but actually medication, especially haloperidol related. Now here are a couple of samples of how the kid writes and draws before PANDAS and what he does after he developed PANDAS. Here is the child again, before and after the diagnosis, and here is before the treatment and after the treatment. And actually, these two pictures, it's this time, it's about 3 months in between. Okay, so, for past 5-6 years, because there are so many different opinions, so many different reviews that have been in literature, and actually you get bewildered. You have all these symptoms. How do you really put it together and reasonably simplify the diagnostic process? So what I've decided to do is kind of copy all the Jones criteria for rheumatic fever that was done many years ago, and I kind of established 3 sets of criteria: absolute criteria, major criteria, and minor criteria, and a mathematical formula how to come up with diagnosis. Absolute criteria is a sudden, precipitous onset of the symptoms. And in my group, it was present in about 96% of the patients or so. The major criteria are 4: presence of OCD symptoms, separation anxiety, tics and adventitious movements, and anorexia. Minor criteria I have split into 2 groups, and reason for that was because I wanted to make sure I have a different brands of symptoms grouped together so there would be no replications. So in the first group is a sleep disorder, as you can see, behavioral regression, aggressiveness, hallucinations, emotional ability, etc. And the group 2 includes white pupils, okay, dysgraphia, and you can see the list here. The diagnostic formula is a mathematical one. If patient has a sudden onset of symptoms, then you have a satisfied absolute criteria, and then you need 2 of major criteria. So 2 of these 4 criteria, plus the presence of sudden onset, should make a diagnosis very likely. In case, and we do have, especially in the patients who come in older age, parents cannot remember, cannot define the sudden onset. So if there is no sudden onset, then formula would be 2 major criteria plus 3 minor criteria. And what is important, at least one of these symptoms under minor criteria should be from each of those 2 subgroups. That's why I kind of split them. In any case, the workup, personally, I have found that there is, we all know, there is no specific PANDAS test, okay? One of the problems I have is by the time I see the patients, the parents are physically, psychologically, and financially exhausted, okay? So I think at that time, you really have to do the maximum from the minimum. So what I normally do, I go with the strep titers, Epstein-Barr virus titers, mycoplasma pneumonia titers, antinuclear antibodies, immunoglobulin panel, and circulating immune complexes. Other possibilities are Cunningham panel, sleep studies, MRI, etc. However, none of these 5 in the second column I have found to be extremely helpful. Cunningham panel is helpful, but in my opinion, in children 12 or above, because less than 12 hasn't shown enough clinical correlation to spend the $500, okay? Now, when we look at each of these in the upper column, each of these tests, okay, please, it must be remembered that anybody can have a strep throat. It doesn't mean if you have a strep throat, you have PANDAS. So, interpretation should be, with reservation. Epstein-Barr virus. Epstein-Barr virus is, at least I have found it, in the small group of patients, 5 or less, who had a negative GAS titers and whom the presenting symptom was acute anorexia. I found positive Epstein-Barr virus titers and negative streptococcal titers. So just for the sake of an argument, I do it. Mycoplasma pneumonia, it's an ubiquitous, today, it's an ubiquitous organism. You can find it in any society. When I was young, and I don't want to tell you when was that, okay, actually it was just a cause of so-called, pneumonia, and it was a relatively rare occurrence. What is the relationship of mycoplasma pneumonia to the onset of PANDAS? I personally doubt there is any. However, I have isolated a group of patients who had active mycoplasma pneumonia, diagnosis of PANDAS, and who had a characteristically severe aggressiveness and physical violence. So this is something that might be looked at. In the immunoglobulin panel, actually, we frequently find IgG low. Okay, we can find some of the subclasses low, but they really don't support or exclude the diagnosis. So when I'm already sticking the kid, and these kids are really terrified of needles, okay? I like to complete the thing because I need the IgA if the kid is gonna get IVIG, and then in these kids, IgE is frequently elevated. Now, one of the interesting tests and surprises that I have found is the circulating immune complexes. I've had about a dozen or so patients who received the serial monthly infusions of low-dose IVIG and actually got worse. And in those patients, I was able to document an increase in circulating immune complexes. And later on, I started to look in all patients for the presence of circulating immune complexes, and I found a certain number of them positive. What is fascinating, at least up to this point, that the patients who had elevated circulating immune complexes were less likely to respond favorably to IVIG than the patients with a normal. So it's something at least to be further, examined and then, used. So the formula that I use is, again, mathematical. 80% of diagnosis is typical medical history, providing you satisfy one of those two formulas. So even with the perfect, fit to one of the two formulas, I'm still gonna be wrong 1 out of 5. Positive response to antibiotic or the steroid burst, it's an important step, and should that be positive, the chances of diagnosis are 90%, and if you have a positive laboratory data, that might increase it to about 95%. So in the end, I still will be wrong, probably 1 in 20, okay? Now, one thing, the parents get frequently bogged down with the blood test. Well, blood tests really cannot exclude the diagnosis, nor they can confirm it. All they can do, just support it. So don't be terribly anxious about it. In the end, it makes only 5% difference. The treatment protocol I use currently is a little bit different than I used 3 years ago. And at this moment, my step number 1 is removal of adenoids and tonsils. So let me reflect on that a little bit. In the year 2000, a group from Greece reported about cohort of about 120 patients with diagnosis of PANDAS in whom adenoids and tonsils were removed. They reported significant improvement in about 60% of the patients. I contacted the group about 2 years later, and unfortunately, most of the improvements reported in the first year slowly have gone down and disappeared. On the other hand, in my own practice, I have found that before Aguilu and the PET Cleary reported Th17 cells business, okay, in patients in whom TNA was not performed, the recurrence rate was about 23%. In patients in whom adenoids and tonsils were removed, the recurrence rate was about 5 to 8%. So there was a significant difference. So step number 1 is removal of adenoids and tonsils. I prefer to observe these kids for 6 weeks, and then, lo and behold, 1/3, approximately 30% of the kids, especially the ones younger than 12, can enter the complete remission that could last for several months, sometimes a couple of years. Should the remission not occur, and kidneys, and I will show you this criteria in a second, we proceed with the second step, and that is the intravenous immunoglobulin. That is then followed by a preventative antibiotic for 1 year. Now, let's figure this one out. They were basically two schools of thought on dosing of IVIG. The replacement therapy was 750 to 1 gram per kilogram, okay? And the standard for high dose was 2 grams per kilogram. So, when you're in my age group, you get kind of bored, so you want to find out, how did they come up with the number? And believe it or not, actually, these 2 grams per kilogram was never scientifically calculated. Somebody woke up in the morning and said, I want to give it 2 grams per kilogram, and actually, I have an institution that was started, okay? So, again, being history buff, I wanted to look, where did the whole thing originates? Well, it's actually the first immunomodulatory treatment that was used, and most of my colleagues cannot remember because that was done before they were born, was it was exchange transfusion for severe jaundice. And it was scientifically proven at that time that the exchange transfusion should be given 2 mLs of foreign blood for 1 ml blood in the body. So if we go by that calculation and try to give a child 2 volumes, 2 to 1, okay, of immunoglobulin, however you look at it, it cannot come to 2 grams. It comes to 1.5 grams. And that's where the number comes from. Okay, now, the IVIG works in different ways, okay? There are a couple of them that I think could be applicable in PANDAS. There are about this, I marked in the red, the ones that you could have an immediate improvement, okay? The number 4, okay, and this is the one, it's this, anti-idiotype complexes, and this is where I believe the problem with elevated circulating immune complexes could be coming from. So let's be careful about dosing, okay? And finally, there is obviously the alteration of the T cell subset and B cell function, and that would go along with the Dritan, Agelus, and Clearis, findings on Th17 cells. Here are the outcomes. If you remember, the group 1 was up to 5 years of age, okay? And so group 1 and group 2 outcomes definition, positive outcome was 90% plus improvement in all symptoms, resumption of normal functioning, and CG, global scale score above 80. We would score it at 3 months. Group 3, those are the ones from 12 and above, the same expectation, but at 4 months post-IVIG. And group 4, those are the older ones, it would be 6 months post-IVIG. And here are the results, okay? In the group 1, the positive results were in 30 out of 39 cases, about 79%. Group 2 was about 73%. Group 3 was 71%, and group 4 was 66%. Now, it sounds great, but here is where the problem comes. Recurrences, okay? So look at this. In group 1, up to 5 years of age, almost every third kid, even more than every third kid, would develop relapse. Group 2, it was about 19%. Group 3 was 13%. And group 4, the oldest one, was 9%. So I have been trying to figure out where is the problem, okay? And what I was able to figure out is simply that group 1, the kids up to 5 years of age, were unlikely to have their adenoids and tonsils removed. In the group 2, they were removed, but not as frequently as in the group 3 or group 4. So there is a possible relationship, but I really have to document it. Finally, when you give IVIG, everybody's thinking it's a big deal. Actually, it's not. Most of the side effects encountered with IVIG are due to 2 factors. Factor number 1 is, does the IVIG preparation contain sugar, especially sucrose, or not? So that's always question number 1, because the sucrose-containing preparations have a much higher incidence of side effects. Question number 2 is the speed of administration. In the old days, it was considered acceptable to use maximum speed of 9 milligrams per kilogram per minute. Well, it turns out if you go above 5 milligrams per kilogram per minute, the side effects skyrocket. So I use 4 to 4.5 milligrams per kilogram per minute, and so far in just about 1,100 IVIGs, here are the statistics. Headache, 1 in 4, vomiting, 1 in 8, low-grade fever, 1 in 10. I had a single case of suspected aseptic meningitis, and I had a case of allergic reaction. We have no idea, 2.5 hours into the infusion. We never figure out what it was a result of. So these are all the side effects I have seen. So let me go over, let me give you some conclusions on the whole thing. Over the past 25 years, PANDAS PANS has been clearly demonstrated to be a distinct clinical entity. It's not a choice. I believe into PANDAS, I don't believe into PANDAS. That's a religious stuff, okay? So it's there, okay? Second important thing is, PANDAS is not exclusively pediatric condition. It likely starts in pediatric age group. However, if you don't treat it, the symptoms remain. They can be controlled, they could be, but sooner or later, some of these patients can deteriorate to the point of complete debilitation or worse. What is interesting is that in United States, according, I don't know which statistic you're gonna listen to, but the incidence of anxiety disorder in adults is about 9% by one statistic, 11% by other statistic. So my question, unanswered question, is how many of those are ignored PANDAS? I don't know. Diagnosis of PANDAS is clinical diagnosis. So, I have a patient who comes and says, well, 3 years ago, my kid had the symptoms, and doctor took the throat culture, did the ASO titer, they were negative, there was no PANDAS. Again, that doesn't mean anything. It is helpful, but negative blood results do not exclude the diagnosis. Now, there have been speculations, especially recently. There are colleagues who are considering 500 germs to be possibly causing PANDAS. I think if you look at if the original premise and original hypothesis is correct, basically there is only one proven true cause of PANDAS, and that's strep group A. There is a possibility of Epstein-Barr virus, but that has to be figured out. Now, just going back to the flares, okay? Flare is essentially sudden worsening of symptoms due to several causes. Now, everybody knows you can get a flare if you have an infection with a strep, but you can get a flare if you have a viral infection. You can get a flare with a flu vaccine. You can get a flare with a teething. What is the difference? And what is important to remember? If you have a flare to a viral infection, or you have a flare to teething, or you have a flare to pneumonia, cause of the flare is always the same. You have an increase, precipitous increase in symptoms for the first week. The peak of the symptoms is between 1 and 2 weeks, and then there is a gradual decrease in symptoms over ensuing 2 weeks. So by 4 weeks, approximately, after the onset of flare, it should resolve. So if you have a child with the virus who has a flare, there is a tendency to put the child immediately on antibiotic. There is absolutely no justification for it. it's going to last the same. If you put a child on steroids, not only that it's going to probably slightly shorten the course of the flare, but could actually worsen the infection that the child has. Now, there was a question to the colleague of ours just before about the teething and the flares, okay? What is fascinating, that you can get the flares with a simple clean teething. You can get it with the tooth eruption. So, you know, my experience is that the possible infection is unlikely to be related to that. So is that a disturbance of the biofilm? Is there a sudden propagation of mucosal IgA? I don't know. But the fact is, you know, mothers come and say, hey, you know, my kid is teething and it's going berserk. So again, I'm old and stiff. So antibiotics, non-steroidal anti-inflammatories, steroids have been proven only temporarily beneficial. And their chronic and repeated use, in my personal opinion, is not justified, okay? There has been a lot of questions, what about the SSRIs, you know, other antipsychotic medication. Let me put it this way. I'm yet to see the kid who had a remarkable improvement with any of these medications. But I have seen scores, I mean hundreds of kids, who actually got worse on it. So, despite of the recommendation on NIH page saying you should start with it, I personally don't use them, nor I condone their use. So, it's just a personal opinion, okay? Now, Dr. Hurley is going to speak about removal of adenoids and tonsils after me with much more authority. But there is absolutely, and I demonstrated in 2 cases when we started it, there is absolutely no doubt in my mind that removal of adenoids and tonsils is not part of a complete, you know, protocol. Not only that it enhances decreases the recurrences, but it likely enhances the effectiveness of the IVIG. So it's something to be considered. Finally, IVIG, in my opinion, appears to be effective, low-risk treatment for moderate to severe PANDAS. Now, remember, guys, I'm from Illinois. We are on the bottom of, you know, states good for living, but we have one advantage. Our insurance companies have to cover PANDAS. and if I can suggest something to everybody, the best way, and I think that was already brought by somebody, I think by Dr. Pasternak, the best way to approach it is money. You know, as a matter of fact, when there was a session in Illinois House about it, they asked me to speak to them. So instead of bringing, you know, all this stuff, I actually brought 2 account sheets from 2 parents, how much they spent before the treatment and how much after the treatment. And somehow everybody got very interested. You know, so this is something you might use, all right? Now, there are a couple of things that haven't been talked about. So you treat the child with IVIG. Kid is doing fine, okay? You discharge him. Is there any special instruction they should know? Well, actually there are. Number 1, this kid must be trained, or you have to drill it in his brain or her brain, that in the future, is that 26, 38, or 64, when he or she gets a strep infection, they're not going to have a sore throat, they're not going to have a headache, fever, whatever. Their only symptom is going to be sudden onset of anxiety, sudden onset of intrusive thoughts, a panic attack. So, you have a daughter, who is going to have 2 children. They're going to bring the strep from school. She must know if she has a sudden onset of anxiety, sudden intrusive thoughts, that last day or 2, it's not PANDAS and it's not electrical bill, it's probably strep. So if they have, and I have been following some patients now for 20 years, if the strep infection is treated timely and correctly, the recurrence should not happen. Number 2, there is, again, it's anecdotal experience, but that's all I can give you at this moment. You know, I generally prefer during the first year to cover any dental manipulation with antibiotic. What I have noticed is that after that, 5 years into the future, anytime these patients have dental procedure of any sort, there is a possibility of flare. What I also had the 2 cases who developed a relapse after the dental procedure. So at this given moment, all I can suggest is using the dental, prevention, antibiotic coverage until further notice. Okay, this is your child, okay? This is a drawing of the patient I had treated 12 years ago. She just went to college in September, and mother was roaming through her things and found this. She drew that when she was treated. So, your child cannot tell you. You see, this kid doesn't have a mouth. They can voice all their problems, but there is always something hanging above them. Yeah, that's your kid, okay? And that's how your kid feels every moment. Thanks.
Dr. Kovacevic is an amazing doctor, as are all of these doctors. We've been, for the last 3 years, giving an award. Every doctor deserves an award. Let's be clear on that. But we picked a special one. So we'll get to all of you like in the next couple of years, so stay with our conferences. But Dr. Kovacevic has been a world humanitarian. You can look him up. You can Google him. For children in Croatia, he's saved many, many lives there, still does. And he saved thousands of children's lives here. And he saved my son's life. Have you guys? And Garrett, we made a little award for him. So Dr. Garrett, you can announce what it is and say what you'd like to say.
First off, I would just like to thank Dr. Kovacevic, who I have not seen for the past 11 years or so, but I'd like to thank him for helping create this amazing organization that all of you are benefiting from. I'd also like to thank him for my and my sister's continued health, and also for the wonderful nickname he gave me on my trip to Chicago 11 years ago that I have not forgotten, Barbie Boy. So this award is for Dr. Kovacevic as a humanitarian for children. So.
This PANDAS business made me really religious because, I have colleagues who believe into PANDAS, then I have colleagues who don't believe into PANDAS. So I'm thinking, what is next, okay? So this afternoon, we're going to discuss that part. I'm glad to see you. And I personally, want to thank Diane because she started most of this parental involvement, and over the years, look where we are. When we met, PANDAS was imported from China for $1 million a year, okay? Now, yeah. So thank you very much, guys.
Thank you,
okay?
Dr.